Okay, I'm happy either way. Firstly, hello, Arnie. It's lovely to see you again. I'll share my screen now. Okay, this is a rather strange topic, and I shall deep dive as much as I can in the next 10 minutes or so. The problem is pelvic congestion syndrome is so common that it is not taken seriously. It's a fairly straightforward set of symptoms of chronic pelvic pain, some lumbar discomfort, painful periods, painful intercourse, and urinary changes. And the patients may have varicose veins, especially after pregnancy, in the vulvar, perineal, or gluteal regions. Now, this describes a very large number of women, and it also describes a huge overlap with many other gynecological conditions. So women are sort of told to get on with it and live their lives and just learn to continue to suffer. But what has changed in recent years is the understanding of this lesion called the NIVL, the non-thrombotic iliac vein lesion, which we now know is not just a left-sided compression of the iliac vein by the common iliac artery, but it can also be present in other sides at about 7 different sites in the pelvis. Yet there's a very strange story where 60 to 80% of the compression is on the left. DVTs are about the same on the left. Ulcers are same on the left. Ovarian vein incompetence is same on the left. And the NIVL is also the same on the left. It's a remarkably consistent statistic. And the issue really is when there's compression of the left iliac vein, the pressure will either go down the leg if the valves are incompetent, either down the common femoral or the saphenous vein. But if the valves hold competence, it will go down the internal iliac vein, which is most often without any valves, and the pressure goes into the pelvis. So it's really a back pressure transmission because of this anatomical compression. The other problem, of course, is we were never designed to stand, but we decided to stand. So in doing so, we have created a compression of the left renal vein, which receives the left ovarian vein between the superior mesenteric artery and the aorta. So you have a compression of the left renal vein at the aortomesenteric angle that then takes the pressure down the left ovarian, and this pressure can be both anterior, which is more common, or you can have a retroaortic renal vein as well. And the nutcracker, therefore, has the characteristic symptoms of a nutcracker, which is hematuria and proteinuria and flank pain. But in addition, you can have all the symptoms of pelvic congestion syndrome. And in some cases, at least, varicocele is actually a male form of the pelvic congestion syndrome. Essentially, pelvic congestion is pelvic venous hypertension, and the term is soon to be changed officially. It's about 10% of them are primary with hyperestrogenic states, but over 90% of them are a venous outflow obstruction, either in the iliac venous system or in the renal system from NIVLs and nutcrackers. But it affects about 10 to 15% of women in their lifetime. That is not to say all of them need intervention, but 10 to 15% of women do suffer. You can also have pelvic escape. We now know that there are these pelvic escape points called the I point, which is the inguinal point, the O point, which is the obturator point, the G point, which is the gluteal point, and the P point, which is the perineal point. And they lead to groin and vulvar varicosities, varicosities in the back of the thigh, and hemorrhoids. So taking PCS history is really an art form. The first thing one has to do is to suspect PCS in patients who have these extratruncal varicosities, which are not in the saphenous territories. So lateral aspect of the thigh, back of the thigh, groin, and vulvar varicosities. It is very rare that they will give you a history when they are with their partner of painful intercourse. So be prepared for a second consultation with the patient by themselves, and make sure, of course, that you have a chaperone at all times if you're going to talk about painful sex the previous night. Remember also that there is a huge overlap with other gynecological conditions. PCS may be 10 to 15% of these symptoms, but 85% remains endometriosis, it remains fibroids and other gynecological conditions. And often the patients don't link the varicose veins on the wrong part of the leg with a previous gynecological condition or history. So it takes some prompting. Although in my practice, most of my PCSs have already been through the mill with the gynecologist for about anything between 2 and 10 years before they are referred to me. So to tease out the history, the chronic pelvic pain has usually been heavily investigated in the past, and it's been treated with laparoscopies, hysteroscopies, and so on. The lumbar pain is usually in the lower back and in the coccygeal region and is often positional. The dysmenorrhea is not just a bit of a painful period, it is typically congestive. The first day of the period and the day just before the period are most severe. Painful intercourse, just painful intercourse is not usually a sufficient history, but the characteristic is post-coital pain. And this pain can last from anything from 1 hour to 1 to 2 days afterwards. And this often leads to upset relationships because the memory of a painful condition after each intimate encounter remains. And hematuria is an important history because if there is frank hematuria, then it usually suggests that an endovascular situation has been crossed and you might have to do a gonadal vein transposition, which is an open procedure. So we start with a standardized questionnaire, which is fairly easy to administer. This does not diagnose PCS, but it tells us whether to proceed to a transvaginal ultrasound duplex. It is, of course, ultrasound is supposed to be non-invasive, but there is nothing non-invasive about a transvaginal duplex. It is psychologically very invasive. So these are 6 questions, and it's a yes or no answer. A score of 5 or 6, PCS is very highly likely. But if they have a score of 3 with chronic pelvic pain that's lasted for 6 months or more, or a score of 4, 5, or 6, we will refer them for a transabdominal plus a transvaginal duplex. And why are we doing a TVUS? Because we are trying to assess pelvic varices in incompetent veins, but also trying to rule out other underlying gynecological pathology. And of course, to assess for involvement of the bladder and rectum, which has some implications in terms of balloon-controlled sclerotherapy in these patients. And there are some specific criteria we're looking for. We're looking for varices which are more than 4 millimeters, a slow flow of 3 centimeters per second or less, a venous reflux demonstrated on Valsalva, and particularly dilated arcuate veins across the myometrium. And the key findings there that allow you to suspect an NIVL and not just a nutcracker is a reversal of the flow in the internal iliac vein. So it flows from the common iliac backwards. There's a loss of phasicity in the waveform, and something called the veno-arterial flow index. I probably don't have enough time to do this in detail, but I'm happy to take questions on it later. So this is a large volume varix on transvaginal duplex in a patient with pelvic congestion syndrome. And here you can see the uterus and this dilated uterine arcade running from about 9 o'clock position to 3 o'clock position in this patient with bilateral pelvic varices. The transabdominal part is really to look for the size of the ovarian vein and the direction of reflux if there is. And of course, you're looking for other causes in the abdomen as well. It is a bit unclear whether it should be 5 millimeters or 6 millimeters, but a dilated ovarian vein is a starting point. But this only tells you that it could be very likely to be PCS and that you should be prepared for an interventional procedure. So I'll start with my first case, a fairly typical young 38-year-old who started having babies early with fairly chronic pain that had lasted for almost 10 years.
Dr. Sriram, sorry to intervene, sir. You have a minute left.
Okay, she was admitted acutely with abdominal pain. That was, CT was normal. She had an ovarian vein of 6.1 with a thickened endometrium. That is her pre-embolization venography, which shows reflux down the ovarian vein. I nearly always use an IVUS to size the embolic device, which is fairly easy to do. I will move fairly quickly now, and you can see typical things, but the picture to look for is a typical nutcracker between the SMA and the aorta, with the renal vein being squashed. She had a plug, of course, had a small wire perforation with some extravasation, but that settled down. And post-embolization, there is no further reflux. And her PCS score now has returned to normal. I'll do a quick second case as well. Pelvic pain since the age of 16, treated at the age of 24. You can see here the loss of phasicity in the internal iliac vein. She had both reflux as well as an NIVL. And you can see the loss of phasicity on this duplex. But on the left side, you can see the huge transpelvic collaterals from the NIVL. She then went on to have a balloon-controlled foam sclerotherapy. I didn't want to embolize her because if she decides to get pregnant in the future, she was only 24, then the coils are liable to move. That's a distal control, that's a proximal control. I will leave the third case out and move on quickly to the summary. She also, of course, had an arboreal left iliac vein stent for her NIVL. So I will move you can, of course, use coil embolization as well if she had been older, but because she was younger, I preferred to only do a balloon-controlled sclerotherapy. I'll leave this third case out, which is a case of typical NIVL that was stented. I will summarize by saying pelvic congestion syndrome is fairly common and is usually pelvic venous hypertension, but it is important to go stepwise and take a meticulous history. They must all have a gynecological assessment, and they should not be treated just as interventions to be done. A PCS scoring, a transabdominal vaginal duplex to rule out all the possible compression sites is important, and each treatment should be tailored for the symptoms of your patient. And of course, if you wish to know much more, you are welcome. We had to postpone our symposium this year, but you're welcome to our symposium in July next year. Thank you very much.